Back to Practice has been made possible with support from Allergan, Novartis, and Notal Vision. We'd like to thank our sponsors for their support of this programming.
Welcome back to Practice, episode 3. And in this episode, we're really looking at academic settings in a pandemic. And we are joined by an esteemed group of colleagues here. Dilraj Grewal is an associate professor of ophthalmology at the Duke Eye Center. We have Adrienne Scott, who is also an associate professor of ophthalmology at the Johns Hopkins Wilmer Eye Institute in Baltimore, Maryland, and Elliott Sohn, who is an associate professor of ophthalmology at the University of Iowa Department of Ophthalmology and Visual Sciences. And Elliott is also the director of surgical medical retina fellowships. I'm John Kitchens from Retina Institute of Kentucky here in Lexington, Kentucky. Today is September 15th, 2020, and as of today, we have 6.6 million cases of COVID-19 and 195,000 deaths. So I want to thank each of you all for joining me today on this panel. We're going to look a little bit at things in your general area, and then we'll talk a little bit more about the academic setting. And in particular, some of the rules and regulations, how they were adopted, how effective they were, and how you're going to move forward in the potential next wave of COVID-19, be it a resurgence or be it a gradual tapering off, or in the advent of a vaccine, how that will look. I'm going to start in Baltimore with you, Adrienne. Thanks for joining us. How are things in Baltimore?
Things in Baltimore are good. You know, we have fairly good numbers in the state of Maryland, approximately 5% infection rate. You know, as far as at Johns Hopkins, we are at about, at least within the Wilmer practice with the retina division, we're about 80% of our volume. So, you know, with the implementation of the infection control policies, we might be maxed out on the number of patients we can accommodate in a day, but we're able to ramp up our volume pretty quickly, and the demand is there. It's kind of a surprise at how many people are just wanting to get in.
You know, speaking specifically about the Baltimore area, you know, we saw New York take a really big hit. Boston also took a big hit. Did Baltimore just seem to evade having a significant outbreak of COVID?
You know what, some of the cities were hit harder. So Baltimore City and within the state of Maryland, some of the counties a little bit closer, bordering DC, Montgomery County, Prince George's County, were areas that were fairly very much affected. But fortunately, I feel like our leadership was decisive and made some good decisions early on. And I do think that Maryland and Baltimore was the better for it.
And, you know, Johns Hopkins has really been at the forefront of the epidemiology of this. I visit the Johns Hopkins global map constantly. Tell us, how have they been so effective at tracking COVID?
You know, it's interesting because you think about, you know, what we do every day, and there are people who set up and they're epidemiologists, and this is what they do. You know, we have a whole pandemic response team that kind of just waits for a pandemic to come along. And, you know, as you mentioned, they've been on the forefront of being able to track the infections when, you know, you have the news media they quote from Johns Hopkins. So, I mean, it's, you know, I think it's basically the infrastructure is set up, fortunately, for this kind of event, which unfortunately hit, and the infrastructure was in place and they were ready to go.
Well, kudos to them. They are absolutely phenomenal, and they have led the world in this, actually, and it's been really amazing. Let's move on to Dilraj in North Carolina. Dilraj, you're at the Duke Eye Center. We talked a few months ago to Sharon Fakrat, and she had some interesting thoughts and insights. How are things in North Carolina right now as far as COVID's concerned?
We've been a little fortunate. We didn't get hit as hard as some of the bigger cities in the Northeast. As with everywhere else, the infection rate did start to rise later this summer, but now we're sort of back down to about 1,000 cases a day in the whole state. And we are at a total of about 185,000 cases so far across the state. So
That's
fortunately...
Yeah, it's amazing considering the population centers in North Carolina, like the Research Triangle in Charlotte, that you all have not had more cases.
Yes, and I think it goes to speak, you know, we had a pretty early stay-at-home order And I think that people, to a large extent, being a university-centric triangle area, a lot of the jobs were able to be done remotely. So people, by and large, abided by that order. And overall, I think it's been pretty well controlled.
And what about in the hospital? How are things there? Are there plenty of ICU beds? And then further, about the ophthalmology clinic?
So yes, fortunately, we were never at a situation where we reached capacity on our ICU beds. There were arrangements made earlier on in the spring, anticipating the wave in terms of triaging patients, getting ICU beds allocated at some of the satellite centers, provisions for repurposing other inpatient units as ICU if needed, having additional staff members available as needed. Fortunately, we did not come to that. So, and that is across the entire state. As of now, the ophthalmology department is back to 80% plus volume as compared to pre-COVID times. We do have protocols in place. We are still have provisions in terms of screening. We are back to basically seeing anybody who needs to be seen and performing surgery on anybody who needs surgery.
Wow, that's fantastic. So elective cases, semi-elective cases like macular holes and epiretinal membranes, there's no delay on getting those done.
Correct. We do require everybody to be tested, and the current policy is within 72 hours of the surgery, they need to have a negative COVID test. If they are COVID positive, then there are protocols for handling that if it is emergent.
And what about your cataract surgeons, Dilraj? Are they back up to full capacity, or are they still limited?
I don't think they're quite back up to peak pre-COVID volumes yet, but they're getting there. I think there is a fair amount of sort of pent-up demand of care that has been delayed, cataracts that have been delayed. So a lot of that is now coming back on. We are seeing them getting busier and busier.
That's fantastic. And Elliott, you're in Iowa City, definitely the smallest of all three of our guests as far as the city's concerned. How are things at the University of Iowa?
Well, things are good overall. You know, we had, because we're a relatively rural state with lesser number of people in the state, and certainly in Johnson County around the University of Iowa, we did well early on. I think, like we've seen a lot of places around the country, the students coming back, the university really made a big impact on a relatively small city. So our city, you know, is around 70,000 people or so, as you probably remember when you did your residency here. And, you know, a large portion of those people are students. When they come back in the fall, you got 25,000 people coming back at one time. And our institution did allow that to happen. And so there was a relatively large surge of patients in the last, or I should say people who were positive in the last couple of weeks because the students came back. There were some days where there was a 50% positive rate of testing for COVID-19 for RT-PCR. So it really got pretty scary. But if you look at it more carefully, those patients were, or those people were really in the 18 to 24-year-old range. So they weren't people outside that range. They weren't the elderly. The number of deaths, you know, people who got really sick didn't skyrocket. It certainly didn't get out of control with our ICUs and the ability of the hospital to control what was going on with patients. But it was really the students that really drove it in this instance. And since then, you know, we have to listen to both hospital kind of epidemiologists, experts, as well as people like at Johns Hopkins, people at the CDC. But of course, we have to listen to what our governor says. And our governor had kind of, because we're a relatively rural state, had allowed a lot of places, bars, restaurants, gyms, all kinds of places to be open recently. And with the kind of surge that happened because of the students here, as well as in kind of the Iowa State University area near Ames and Des Moines, on the other side of the state, 6 counties were shut down regarding bars and restaurants after a certain hour. And so that has really actually allowed the number to really fall pretty in a pretty predictable way, but in a very good way too. That is, I think, safer for everyone.
And are the college kids back full time now? Are they in school, or are they doing more virtual school? How's the university handling that?
Well, the university has allowed the students to come back. And so many of these students did come back. I think there is some virtual classrooms and learning still happening, but there have been a lot of the students and teachers back in session. I think there were some days where it was, in the first couple of weeks, there were hundreds, if not over maybe 1,000, just in this local area that had positive patients, and most of them, again, students. And I think there were, over 1,000, and then about 21 faculty who tested positive in that same period over a couple weeks. So you can see the dramatic difference between professors and teachers, faculty, staff versus the students. So yeah, it's really, these invincible kids going out to bars, going out to places where they shouldn't be really hanging out indoors, especially without masks and infecting each other.
And how about the department? How is the department doing there?
I think the department is doing really well. I think the hospital responded in just the right fashion very early on to this pandemic. Of course, like many other places, we shut down elective surgery. And so in the beginning, there were certainly some of my colleagues in optometry, cataract surgery, a lot of the elective cases. And, when we had macular holes, we would put those off. Those kind of surgeries were really put off for quite a long period. But once the elective surgery ban was lifted by our governor, then we really started to see patients come back again. But it was a matter of us making sure the hospital was safe, making sure that patients were safe, and convincing patients that it was okay to be here. So there were a number of things that the hospital did and our own eye clinic did to try to protect our patients. For instance, not letting visitors come in. So for a while, there were no visitors at all allowed. And that was really challenging for taking care of patients. And since then, there have been some revisions to that, exceptions to that, post-op day one patients who are about to go to surgery, patients on the day of surgery. So in terms of some exceptions, I think there's certainly been an evolution. And if you want to know some of the exact details, like even I will have to look at the exact protocols of that day. Like, what are we supposed to do today if a patient's positive for COVID? Like, what are we going to do? Because it's different today than potentially a couple of weeks ago. As guidelines change, our epidemiologist and our hospital responds in a way that is trying to protect our patients as well as our staff. And that's one thing that a lot of patients really remark on, is that they come now to the eye clinic and the waiting room is like relatively empty. Normally our waiting room, as you know, for retina clinic it's just jam-packed full of people. And now, patients they actually really like it. So they don't mind coming in. They say, well, this is actually a pleasant place to be now, because, even though my spouse or my loved ones can't be with me, like, I don't have to be close to other people and I can get in and out relatively quickly. So we try to make things efficient as well.
And Elliott, when these decisions are they made from the upper levels of the university hospital, or are they made on a department by department basis?
I think both. I think we certainly listen to the guidelines and trust the people kind of at the top, because they're getting information from the top epidemiologists. And we have one particular researcher who is a real expert in COVID and coronavirus before all this happened. So we have a lot of expertise, and we're very fortunate in that sense, and we trust them. And so, we're also fortunate that our chair, Keith Carter, is also, he's been chair for, quite a number of years, and he's well integrated into the hospital administration. And so there can be a lot of positive feedback that happens there on both sides. So there's feedback from him to provide guidance to the hospital administration, as well as vice versa for the department from the hospital.
Adrienne, same question for you, but a little bit different. At Wilmer and Johns Hopkins, does the ophthalmology clinic have a different set of rules than, say, the ear, nose, and throat clinic, than, say, dermatology would, or does everybody have to abide by one overruling principle there?
Yeah, so we operate and we're governed by the overall hospital epidemiology and infection control center, the HEIC. And so basically we have representatives among our leadership to be able to sit in those meetings and participate in those meetings to understand and hear kind of the latest guidance. Because as we can all recall, in the first days of COVID, things were changing rapidly, and the rules were really, kind of evolving as we went along day to day. And so, with that information, one of our, vice chairs from those meetings would kind of gather all us Wilmer medical directors together, and on sometimes the calls were up to 3 times a week. It's interesting now, they're kind of once every other week. But kind of when we were first trying to figure out what was going on and how we were going to synchronize practices, we met by phone conference call fairly regularly. So, we were governed by these overall regulations, but interestingly, we had to try to adapt them to be ophthalmology specific, like, okay, I have to wear a face shield all the time, but I need to have an indirect ophthalmoscope. How do I wear a face shield, and how do we adapt that to meet the rules while we're able to do, things that are specific to our practice? So, also a lot of the rules were somewhat tailored to inpatient settings and those types of patient contact situations. And so we had to try to, kind of adapt them to our ambulatory setting and surgery center as well. So, a kind of a hybrid of taking the overarching guidelines, but also trying to adapt and evolve them to our ophthalmology practice as well.
And what about for the operating room? Do you all operate at a surgery center or in the hospital? And did you have to abide by the principles of the hospital, or did you have separate for the ophthalmology side of things?
Interestingly, so we have one big hospital governed main OR. It actually is Wilmer specific OR as a Wilmer specific OR, but it's in a part of the overall hospital umbrella. And so we follow those policies. There are 2 Wilmer ambulatory surgery centers where we perform ophthalmology care in our suburban practices, and that actually is a different governing body. So that was also kind of an interesting, synthesis of one governing body and one ASC, overseeing our ASCs, and then the governing body overseeing the hospital-based surgeries. And so sometimes those things weren't quite consistent. So, so we had to try to, it came to a point where right now we are consistent with one another. So as Elliott mentioned, all patients, asymptomatic patients for pre-op, receive pre-op COVID testing, PCR testing, and has to be within 72 hours of the case.
Okay, fantastic. And Dilraj, at Duke, who was making the decision? Was it coming from the university, or was it coming from the heads of the ophthalmology department?
Similar to how Adrienne and Elliott mentioned, it was a data-driven decision-making, especially as we moved past the early days of the pandemic, and taking into account inputs from the infectious disease epidemiology folks, as well as our administration. And then there was some leeway in terms of trying to individualize things to the different departments. And some of it was just logistic based. For example, the eye center is currently an entry to a fair amount of employees coming into the hospital. So therefore, that was a gateway to employee screening for a large proportion of folks as they came from the parking garage into the hospital. So there were similarly, adjustments that were made for that entry point so that patients could also enter at the same time. And in terms of, I think the visitor restriction was really helpful because it reduced the overall burden in the clinic in terms of separating out the seats in the waiting area, in terms of the burden of cleaning the rooms between patients, and also in terms of moving patients from one waiting area to another, for example, from the initial waiting area to the tech room, imaging, and so forth. And that's been really helpful. And you can use technology as a sort of an augment, because if the patient's attendants are waiting in the car, you can always connect to them while they're in the room. So things like that can really augment some of the experience that is missed out when they're not there. But that has helped the flow quite a bit. And as of now, things are quite standardized in terms of most people know, they know what to expect when they come into work. The employees know there's a protocol in terms of who needs to be tested. The patients are also becoming more and more familiar. We have those rules in terms of waiting in the car. If the waiting room is full, we will give you a call when you come in. things like that, are trying to streamline the process, because the overall goal is so that patients spend the least amount of time they need to in the facility, and can move along the whole process pretty efficiently.
Dilraj, we've heard of some practices and some academic institutions actually calling patients before they come in and pre-screening them. Is Duke doing anything like that?
So we have multiple locations, and some of our satellites have just the eye clinic, whereas others are more of a multi-specialty clinic, and some of them are actually hospitals. So some of the ones that are an eye clinic only, we are doing that. So that just to reduce the number of patients in the eye clinic itself at any given time, we can screen them while they're outside, while they're in the car. Similarly, if they're getting backed up, we can ask them to leave, and then we can make their appointments over the phone while they're in the car, rather than having them have a backlog at the check-in, check-out counter.
That's a great idea. I hadn't heard anybody talk about that at checkout. And what about telemedicine? Are you all doing anything as far as telemedicine or any kind of remote imaging and interpretation, and then calling patients and discussing the findings?
Yes, we did a fair amount of telemedicine early on, just because there was no other option. You had to get in touch with the patient somehow. I think for retina itself, that has come down because a lot of patients are actually coming in. There are some options in terms of patients coming in, for example, just getting a pressure checked, getting a visual field or an OCT, and then we can call them later on with the findings. That is being done, but on a relatively small scale. It hasn't really, because our first priority, I think, is to take care of the patients that are actually coming in, and so that the resources are not taken up by other patients. Right? We are actively working on that sort of a hybrid model of teleophthalmology, where imaging is done at a distinct visit, and then the more time-consuming part of patient interaction and discussion can be done electronically.
And do you think that's applicable to retina, or do you think we treat so many patients when they're there that it may be a misgiving for retina to think that that would work for us?
I think from the patient standpoint, it's better. So, for some patients who are coming in once every 6 months, once a year, for a relatively slowly progressive disease, it makes them feel a lot more comfortable to come in at a time when the clinic is relatively empty, or over the weekend or in the evenings, and not have to deal with the interaction of dealing with other patients. It, I think, makes their family members more comfortable, especially the ones that are in assisted living facilities, nursing homes, because for them to come to our clinic is an ordeal. They have to go through their own set of approvals to be able to come to our place. And I think it just gives that additional layer of comfort.
No, that's a great point. I didn't think about the after hours. That makes perfect sense. Elliott, at Iowa, you all have a very unique telemedicine AI type of research. How are you using that during the COVID-19 pandemic?
Yeah, so of course, IDX, and now it's called Digital Diagnostics, started by Michael Abramoff, is really kind of going global. And so we've had some use with that in our clinics, but really fairly limited. It's really something that's being deployed and meant to be in primary care offices, in places in the rural areas that don't have access to ophthalmologists, optometrists to be able to do the kind of yearly diabetic eye exams. So our use of telemedicine has been relatively limited in the retina clinic. Of course, we do call our patients in advance and, like the others, screen, make sure that they're not having any symptoms. And when I talk to like my secretaries and people who screen the patients, they say no patient has ever said that they've had the symptoms and then they still come in. And we were for a while, interestingly, I will just related to that, when we started doing testing on all patients coming to the operating room who were asymptomatic, supposedly asymptomatic, 1% to 2% were testing positive, who are coming to the operating room. And we do our testing within 24 hours of the surgery. And that's a requirement by our hospital. So I do surgeries on Monday. So it's challenging for patients because they have to come on Sunday and they have to come to the University of Iowa for their tests. We won't accept tests from outside the university. So they have to come to the University of Iowa. Some of these patients come from long distances, hours away. And so then they have to potentially stay multiple nights in the hospital.
Yeah, you're absolutely right, Elliott. That's in Iowa. That is a very, very rural state. Adrienne, how about you and Wilmer? What are you doing as far as telemedicine is concerned?
You know, personally, I found telemedicine fairly limited to be able to really get an effective retina visit across. I have had colleagues in ocular oncology and inherited retinal degenerations that really made it work for them, you know, to be able to counsel the patient. A lot of their visits are counseling and planning. But you know, for me and most of my retina colleagues, it wasn't very high yield for us to do the telemedicine visits. That, and there was still uncertainty about coding and the billing aspect of things. So again, it was somewhat an evolution as things were going. So I did not use telemedicine.
Yeah, I'm in a bit of agreement. We tried to set up telemedicine early on and really put a monumental effort into getting something established, but we found about half of those patients who ended up coming back for a treatment, and it really didn't seem to save much time. And then finding people to work on a Saturday was another whole issue as far as that was concerned. I want to talk a little bit about training. Adrienne, you all do a huge residency program, a lot of fellowship training. How are you dealing with the training aspects for your residents and fellows?
You know, it's interesting. I mean, it definitely affected things, and especially some of the graduating residents who were on their, you know, their major cataract surgery block, right, you know, right when COVID hit. And so, you know, they were you know, fairly disappointed that their surgical volumes were impacted in such a way. You know, they would be kind of hanging around the OR just waiting for any case to go. You know, it was great to interact with them, but they unfortunately had a lot of their elective cases, you know, taken out of their control. So, you know, now, you know, the volumes are not quite up to capacity, but their, you know, elective surgeries are proceeding. So the volumes are a little bit, you know, starting to rise now. And we have residents and fellows in our clinic now, seeing patients with us. And, you know, during, you know, I guess maybe probably March and April, we had pulled residents off of the, you know, the elective rotations and the subspecialty rotations. And, you know, these residents were actually, you know, some of the ones that would, you know, we were training to see consults on COVID positive patients and patients who had ophthalmic issues. You know, we were, you know, geared up to, you know, we were asked, all of us were asked, you know, are we going to be deployed, and what aspect could we be deployed to take care of, you know, COVID positive patients. And, you know, our residents, you know, volunteered and stepped up, and I don't believe anybody was pulled into actual clinical care of COVID positive patients, but they were prepped and ready to do so.
Wow, that's amazing. And on the interview trail, how are you all going to handle interviewing residents, fellows? It's a whole different dynamic when people can't do away rotations. How are you dealing with that?
All right, so I guess one of the positives of it all, as I tell some of the individuals whom I've mentored, is everybody's on the same playing field. So everybody's virtual now. So, you know, it's definitely a disadvantage to miss out on seeing a place for yourself in person and getting a feel for the atmosphere. But, you know, getting around it certain ways by trying to plan a dynamic virtual interview day and being able to try to, you know, do cute things like the fellows making a video of a day in the life of a fellow. And that's something maybe every applicant could watch in advance. So lots of ways that we can try to kind of do an end around and give someone a flavor of the program. But, you know, it's just not the same. You know, one positive of it all is that I think everyone's going to save a lot of money on the, you know, all the plane fare, and maybe they can experience many more programs if it's just a click of a button, as opposed to having to fly across country and you know, and try to travel to various places.
You know, you're absolutely right. There's so much that's lost by not having a person come interview, you know, in person. And I'll tell you a couple of things. Our examples, you know, my secretary would always come back and say, I like this person or I don't like this person. And that's an interaction that is completely lost on Zoom calls. And the fellows would always take the applicants out the night before they interviewed. And they come back and say, I really don't like this person, or I really like this person, or this person's really interested in Kentucky. And so you just lose that. And I just worry that we're not going to be as good about picking our fellows. Elliott, you're the fellowship director. How's Iowa going to deal with the fellowship program, interviews, and also residency?
Yeah, so like other programs, we're going to be doing it via Zoom. And so we're organizing all that right now, looking at all the applications, and hopefully we'll be sending out interview invites very soon. but we're organizing it. And like Adrienne said, there's some flexibility with this because it's on Zoom. Now we're going to actually do our interviews on Saturdays, which is not ideal for anyone, but it allows us to not have to take away time from our clinics, our ORs, our research, and we can do this maybe over a kind of like 7-hour period on 2 Saturdays. So that's our plan for the Retina Fellowship, and we're doing some things to meet this challenge of trying to engage the applicants in a unique way where, you know, maybe people were already hesitant to come to Iowa City because they're like, it's Iowa City. Like, why would I go there? And now we have to meet that challenge in a different way where we can't obviously bring them here, but we can show them videos. We can try to, show some pictures of some very unique things that Iowa has to offer in terms of like the outdoors, nature, and those kinds of things. So yeah, it's just a different way of trying to interact. Some people say that maybe people at their home programs will have an advantage or maybe prefer to stay at those home programs. But I think just like any other year, we're going to rely heavily as well on our friends in Retina. So who our colleagues are across the country, and say, you wrote this great letter. Is this the real deal? Is he or she the real deal? Or we'll call some other people, program directors or other people who we know in Retina programs at those institutions, which we always do, and just say, just tell us about this person. And that's why it's nice to have those good relationships with people, because that can go back and forth, because they may be interested in someone at Iowa, because we have 2 people applying for Retina Fellowship. And so I think that can go both ways for this year. I do think that for residency, I think it's going to be very similar. We've been talking to our program directors, Tom Oding, of course, and our associate program director, Paulina Kemp, who's doing a phenomenal job, who's coming on doing some administrative leadership duties with this. And we're going to do some similar things where we're basically going to have an interview day of, the applicants with the faculty, probably paired. For us, I think we're also going to try to engage some of our alums, which is very unusual. So we're going to do that. Maybe they'll call you, John, to do that. But we've already been reaching out to people, and our alums are really, they love training at Iowa, and so they're really happy to talk to people and try to convince people, because without visiting, you don't really know. So you have to talk to people who've been there, and so we open up our Rolodex to the applicants and just say, you can just call any of our previous faculty or certainly our fellow alumni, just talk to them about the program. What was their experience like, and how did it help them in their current practice? It's
such a family oriented practice out there. It just really is a tight knit group with very little change, which is really a nice thing. I don't think you have any problem when you bring fellows out in September or October selling them on Iowa. It's only when you get to January that selling them on Iowa gets a little bit tough. Dilraj, how are you all handling the fellowship interviews and residency selection process?
I think very similar to what Elliott and Adrienne mentioned. It's going to be a new experience for all of us, and we're trying to make it as interactive, as engaging, as realistic as we can, relying on our fellows, like the ideas of giving the applicants a tour of what their day is like, having an individual discussion with them, showing them some videos, more sort of one-on-one discussions, and then of course relying on our friends and colleagues, across different programs as well, to talk to them about the applicants.
That's fantastic. Dilraj, back to you on this question. How's research been affected? And I don't mean the phase 3 clinical trials. I mean the basic science type research that an academic institution of Duke's reputation is well known for.
So initially in the spring, everything was shut down. It was a blanket order that all research needs to be halted. And a large extent was that, folks couldn't come in because there was a stay-at-home order. So human subject research as well as basic science research, with the exception of those who had critical cell lines that needed to continue. So there were exceptions made for that. And after that, there was a sort of data-based, data-driven approach stepwise to allow people to resume research. So what they did was they have clinical research units for every department. And they were tasked with looking at the protocols that were active prior to COVID or those that are supposed to come on, assess their impact, their importance, their viability, get feedbacks from investigators in terms of what kind of resources are going to be required to get those protocols back in place, other collaborators, and then make a case-by-case decision in a phased manner as to which protocols are going to be online. So that process is still undergoing. We are in phase 2 of that process. So a majority of our research protocols are now up and enrolling. There are certain restrictions, of course. Clinical research has to abide by the restrictions put in place in the clinics themselves. There are restrictions in terms of how many patients you can bring in one day for a research study and those types of things. But for the most part, now it is back in place.
And has this affected the grant writing process, the grant acceptance process? Has the government slowed down giving grants, or has there been any change on acquiring funding?
Since this was a pandemic, everybody was affected. And in fact, the grant authorities have been very understanding. There have been no-cost extensions that were provided by several sponsors, and in fact, there was also allocations for idle effort, because even though you're not able to participate or do the research, this is still your job. And there are many people who are dependent on those grants. So that's actually been very nicely handled by both the federal authorities as well as a lot of the private grant institutions.
That's fantastic and actually really surprising. Elliott, same question for you. How has the research been during the pandemic? Have you stopped doing some of the basic science research, and how's the grant writing process?
In the beginning, it was very challenging. They certainly shut down the research labs, except for essential research that had to be done, where animals had to be done within a certain time period for experiments. So there were some experiments that were still going on. It was highly limited basis. There were some experiments that had to be kind of halted, and that's difficult. That's frustrating for our programs. What we've done recently at the Institute for Vision Research is, because of the difficulty in obtaining tests, my colleagues Ed Stone, as you know, Val Sheffield, and others have actually started doing COVID testing twice a week for all of our Institute for Vision Research employees. So we're doing that for them as well as our immediate family members, doing it twice a week. We did blood at the beginning, and now we're doing a sputum sample that's been verified by Val's lab to really test people, to look. We have the capability in our IVR to do 4,000 PCR tests per day for COVID. And people like Ed and others were talking to hospital administration and saying, look, we can do a lot more tests than you guys are doing at the moment, at the beginning of the pandemic. We can help. And so now that's how we're doing it, is by doing this research-based study, but in a way where we'll be able to get some information. And if something turns out positive, we can assess, is this real? Should we likely send them home, be on quarantine, or are the family members or close contacts also positive that requires that employee to stay at home? So that's over 100 people in our IVR who are getting that done. And so I think very effective for trying to do certainly testing and determining what we can do with our research unit. And with the students, we expected there to be a big surge with these students. And what we didn't know was, is a university research labs gonna get shut down again because of the surge? And so we basically started this testing to be done as well. So in case they try to shut down the university, we can say, look, well, we have mission critical things to restore vision to these blind patients with our stem cell based treatments. We have our own, we can keep going because we can do do this ourselves. So I think that's a very unique thing that's happened with our research labs at University of Iowa.
That's amazing. So Carver Lab and the MBA bubble both are testing their employees twice a week. Only Ed would think and Val would think to be able to do those things. Adrienne, for you, and we'll wrap up on this question, how's clinical research going? As far as clinical trials in an academic setting like Wilmer Eye Institute, are you able to maintain those follow-ups with patients and maintain those studies, or have they kind of come down and said, no, put a hold on everything?
Yeah, as Dilraj and Elliott were describing their experiences, ours at Hopkins have been similar. We were shut down completely. during the spring, and then had a gradual phase in, for essential researchers. Right as of now, clinical research trials are ongoing, patient visits are allowed. So we're pretty much up and running. One interesting thing that actually was a phenomenon of everyone being home in the spring is that people seem to be a little bit even more productive about writing. So there was, a time to finally sit and write that grant, or, finally finish that paper. And so that was one positive of having to be home.
Do you think there's going to be a lot lost by that absence of research for 2 or 3 months, that there's going to be a lot of studies that are kind of unfulfilled or incomplete because of it?
Well, we're definitely playing catch up. A lot of the, the industry clinical trials were allowing, exemptions to certain, study visit windows, because obviously, as Dilraj mentioned, it was affecting everyone. So, there was some grace within the clinical trial protocols. But now, I think overall, everything is going to balance out and we'll be on track, because right now we're catching up and things are proceeding at a good pace now.
Well, that's good to know, because there's so much effort put into clinical research in those trials. I want to thank all of you for being on tonight. Dilraj, Elliott, Adrienne, thank you all for listening to episode 3 of Back to Practice, and stay tuned for further episodes as we continue to dive in to this unique and unfortunate phenomenon of COVID-19. Thank you all for joining me.
Back to Practice has been made possible with support from Allergan, Novartis, and Notal Vision. We'd like to thank our sponsors for their support of this programming. This webcast podcast is intended solely for ophthalmic healthcare professionals and ophthalmic industry representatives. By accessing this webcast podcast, I acknowledge that Bryn Mawr Communications LLC, herein BMC, along with all third-party corporate supporters of this webcast podcast, makes no warranty, guarantee, or representation as to the accuracy or sufficiency of the information presented in this webcast podcast. BMC, along with all third-party corporate supporters of this webcast podcast, do not endorse, approve, recommend, or certify any of the opinions or information presented or mentioned. BMC expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or other damages arising out of any individual's use of, reference to, reliance on in this webcast podcast.